upcoming neuroprosthesis seminar. So today is Andre Machado, obviously. Next month on the 21st is Doug Weber from Carnegie Mellon University. In April 11th is Emery Brown. And on May the 16th is Vivian Mushawar. So we have a very distinguished lineup starting today. Well, yeah, we didn't have one in January. I didn't want to disrespect anyone. We also have a number of First Tuesdays coming up. They've been scrolling across the screen, I think. Please, this is a great opportunity for you to work with your colleagues to present your ideas and to listen to other people's ideas and help them. So it's a great way for us to help each other. Okay, it's really a great pleasure to introduce our speaker today, Andre Machado from the Cleveland Clinic Neurological Institute. He's the chair of the Neurological Institute at the Cleveland Clinic. He's Associate Chief of Staff at the Cleveland Clinic, the Charles and Christine Carroll Family Endowed Chair in Functional Neurosurgery, Professor of Neurosurgery in the Cleveland Clinic Lerner College of Medicine, and has joint departments in neuroscience and biomedical engineering. He has an MD from the University of Sao Paulo in Brazil, completed his residency there, received his PhD from there, and then he came to the Cleveland Clinic in 2004, did a fellowship in stereotactic and functional neurosurgery, and has been on the staff at the Cleveland Clinic ever since. His clinical activities include doing deep brain stimulation for Parkinson's disease, tremor, dystonia, obsessive compulsive disorders, as well as surgical procedures for patients with a number of other syndromes, including intractable pain. But he has a big research area as well, and that's what we're going to hear about today. So he leads several deep brain stimulation and neuromodulation clinical trials. He's been awarded a NIH Director's New Innovator Award for deep brain stimulation for thalamic pain syndrome. And his current research is aimed at developing novel treatments to promote rehabilitation after stroke. And I think that's what we'll hear today. So please, help me welcome our speaker.
Thank you. Well, thank you very much for having me. Thank you, Bob. That was very nice. Dominic, how are you doing today? And what I want to talk about today, and we have an intimate group, so I would like you to stop me throughout the presentation. We can make this a conversation, which is rare opportunity. I think most of us cannot eat another PowerPoint in our lives. We have had enough of them. And I just want to make this into a dialogue. This is a 15-year-old project. We have just begun the phase 2 randomized control trial. The first surgery of the phase 2 was in January, just kind of like exactly a month ago. And what I want to do today is to walk through our reasoning of how we got here sorry about that. Oh, sorry, disclosures. The relevant one is Inspire. It's a spin-off of Cleveland Clinic and the NIH funding. What I want to do is to walk through the concept, the hypothesis we created, then what we did before we did any human work. This was unusual, it was different, it had never been done. So we did several years of preclinical work in really rodent models. Then how we got into phase 1, look at the data from the phase 1 study that is a non-controlled study. It's an open label study. And what those data showed us in terms of behavior, hi Mike, in terms of behavior, in terms of brain metabolism, what we learned in electrophysiology. This is a point of opportunity for collaboration with this very group here that I'm always trying to squeeze Bob for someone to help us do this work. And then just a quick conclusion. So let's go through the rationale to start. What the problem we're trying to solve is recovery after stroke. To date, recovery after stroke is predominantly done by means of rehabilitation. Physical therapy, occupational therapy, you guys are experts in that. the idea of using augmentation, either by a drug or by electrical or magnetic stimulation, is not new. This has been around for decades. What is hard is to get a result out of it. The literature in TMS is very robust. If you have an interest in reading it, very robust. There are thousands of papers on using TMS to prognosticate or try to improve the outcomes after a stroke. Stimulation of the cortex via an implanted lead, dural or subdural stimulation, was extensively investigated in monkeys by Dr. Nudo's group. I know he has been a speaker here. In rodents by Dr. Jones's group. They were together investigating at one point. They were collaborators. And then it went into an industry study, phase 1, phase 2, phase 3, which unfortunately didn't work. The control group, exactly the same as the experimental group. What we are proposing is to modify this therapy, this technology that we use a lot, right? We know this relatively well by now, 20 plus years of doing this for movement disorders. Modify that some to see if we could use a subcortical network, a natural circuit of the brain. Yes. Yes. Oh, I asked you to. Please, Dominic.
Go back 1 minute.
I will, if I know. That?
So you said the cortical stimulation did not work, is that what you said?
Yes.
And the electrode replaced where?
The investigation here was done placing the electrode in what the investigators defined as the perilesional zone. And the perilesional zone was defined as the area that was active during an fMRI task of finger tapping. The area that was changing blood flow is the area that the investigators placed the electrode. One of the criticisms of the design of this study is that not all centers used mapping to identify the motor strip, and that may have caused some methodological variance.
So tell us about the other one, TMS, TDCS. What work are the current results?
There is no therapeutic benefit demonstrated. Meta-analyses have been done by leaders in the field like Franny, Harvard Medical School, showing that there is no demonstrable therapeutic benefit. Most of the literature in TMS, including the one we do with Ila Plau at the Cleveland Clinic, that she's the PI, are studies trying to demonstrate facilitation, as well as studies investigating the mechanisms of natural recovery associated with plasticity, with the natural plasticity. And yes, people trying to figure out therapeutic ways, but none has achieved a certain magnitude of effect that would lead, for example, to the therapy being FDA approved. The technology here currently demonstrated clinically for clinical use and FDA approved, reimbursable for the treatment of depression, bipolar disorder and depression. TMS is a routine, well-demonstrated therapy, and the advantage of TMS over the prior therapy, which was electroconvulsive therapy, is not that it's more effective. It isn't, but less harmful. Electroconvulsive therapy highly associated with memory loss, TMS more focal and less associated with memory loss.
More questions.
Yes.
Isn't it tough to generalize whether something works or not when we're not looking at the rest of the system?
Yes.
So for example, if you're doing spinal neuromodulation, they would always say, well, really, it's the therapy that's doing it that's paired with the stimulation, and that pairing is really what's doing it.
Mm-hmm.
That, the stimulation alone is, it's by itself.
100%. It is very difficult to generalize, and one of the difficulties in the field is to separate out during early phase investigation. I'll talk about it. What is the result of physical therapy alone? Because physical therapy works, right? And what is the improvement that is potentially attributable to the intervention you're studying? And by the time you can separate them, You are into advanced studies and you have already committed quite a bit. And we made an attempt in our phase 1 design to try to separate one thing from the other, which I'll show. But the proof in the pudding is only going to come in the current study, when we will randomize people, sham control, right, blinded, to physical therapy alone. The DBS is implanted, but we're not going to activate it, versus physical therapy plus DBS. That will be the only true way to distinguish effects from physical rehabilitation alone to those of physical rehabilitation plus DBS. My expectation is that this technology that I'm working on will have zero benefit in the absence of physical therapy. In and of itself, I think it's ineffective. We never tested it, but that's my assumption. I think it is a rehabilitation booster. That's what we're hoping. It's a booster of rehab. Thanks for interrupting me. Please continue. So let's see if this plays. Are you able to play this? There is a button here that maybe I can do it. Oh, the video didn't embed, did it? Yeah, I want to show you the network. So the network that we are targeting is a disynaptic network. So we're targeting the dentate nucleus of the cerebellum, one excitatory synapse in the thalamus, multiple thalamic nucleus, and second excitatory synapse to the cortex. The spread into the cortex is wide. It spreads all the way to the prefrontal cortex, to the parietal cortex. Why do we care? Because we are enrolling these patients a year after a stroke. The encephalomalacia, the cavity, has already been created. We're not going to help that brain grow again, right? It's not regenerative. What we are trying to do is to augment the natural plasticity that occurs in the periphery of the perilegional cortex. But unlike the work done with cortical stimulation, Dominic, we don't have to know here exactly which area is lighting up during an fMRI test, because the stimulation is really directing to the entire perilegional cortex. One putative second advantage here, hypothetical second advantage, is that when you're applying stimulation from the top, from the cortex, you are dealing with the orientation of the neurons, very variable, and whether you're hitting the neuron vertically, diagonally, or horizontally, the effect can be different. DBS obviates all that because you're stimulating through the pathway that will be delivered to that synapse, regardless of its geometrical orientation. I told you that we started in some preclinical experiments. And there were several reasons for doing this. One is fear, right? You don't want to do this in humans before doing some investigation that supports it. The other one was trying to find out the frequency of stimulation. When we do deep brain stimulation for Parkinson's disease and essential tremor, we use what we call high frequency stimulation. Case Western would call that low frequency, I understand, but to us that's high frequency, which is something around 100 and a couple hundred hertz. And the intent there is to produce a lesion-like effect. What do I mean? When we do thalamic deep brain stimulation for tremor, the most common application, it suppresses the tremor. Gets exactly the same result as you get if you do a thalamotomy, if you damage the brain. If you do a pallidotomy, you get a similar result than DBS of the globus pallidus. And when you're trying to treat someone that has a hole in the brain, trying to produce another lesion-like effect, not what we were going with, we wanted to produce augmentation of function, not reduction of function. So we did a few studies. Ken Baker is my partner in this. And we titrated every frequency in increments of 10 hertz. And we studied it in relation to the system. And we learned that lower frequencies, around 30 pulses per second, 30 hertz, were more likely to augment the magnitude of the motor evoked potential indexed by intracortical microstimulation, right? Click, clack, click, clack, click, clack. That's just the testing stimulus. And then we would turn on the DBS, which is the conditioning stimulus, to see if we could modulate the excitability. And what mattered here is not that 30 hertz or 20 hertz stimulation increased it, is that it was sustained over time. Whereas 100 hertz, for example, what we use in Parkinson's disease, produced an enormous peak of excitability that quickly reduced and became net inhibitory, just like it's supposed to. Then we learn how to do physical rehabilitation of rats. It's a field of its own. We did not invent this. It's well validated in the literature. But this is rat physical therapy. You serve them pasta through a fenestration. They have to use the affected paw. And the number of pieces that they are able to grab, break, and eat versus the number of pieces that, for example, they drop and they lose, and the ones that they cannot reach, is an index of how much they are improving. So think of it as like the Fugl-Meyer version for the rat. There are different ways to do this. You can also use a sugar pellet to see how they are reaching the sugar pellet, still through a fenestration like this. The reason we like this one is that it's easier to standardize, it's less operator dependent, and we learned a way to bring the task straight to the animal. So we are not taking the animal out of the cage. And the reason we don't want to take the animal out of the cage is that we don't want to untether the animal during the task. We want the stimulation to keep going.
What was the injury?
We tried a few. So there were two types of injury done here. One injury in one study was a microsurgical ligation of the middle cerebral artery with temporary occlusion of the carotids. So you do a cervicotomy, isolate the common carotid, you put a vascular loop around it. Then you do a craniotomy, go into the origin of the middle cerebral artery, right off the carotid. Under the microscope, you buzz it and cut it. And then you tie the carotids for 1 hour. And then you release that mimics stroke with reperfusion at the release time, produces a gigantic stroke. The other one that we tried and used frequently was endothelium injection. So you do a craniotomy, map the motor area of the animal, and you inject endothelium into the motor cortex. So two different ways of producing ischemia, but both are valid. We then took a few cohorts, and this is one example, and randomized them to either receive active DBS, meaning this electrical cable was running current, versus sham, right? The electrical cable is connected, everything is the same, but you turn on the stimulator, but you keep the current at 0 milliamperes, 0 microamperes. And the dotted line here shows the drop of function at the time of stroke. And the solid vertical line is the day that we either turned DBS on or we left it off. And in several times, we have done this a few times, the group not receiving DBS tends to remain constant or actually worsen a little. And the group receiving DBS tends to recover. We have reproduced this, Chinese group has reproduced this. Gary Steinberg at Stanford has been able to reproduce it as well. We studied a few mechanisms. I'm going to only show one so I can go to the human data, which is three-dimensional electron microscopy. This is done by Bruce Trapp's lab. It's a technique that they developed. It's similar to how you stack an MRI. So they do slices of three-dimensional electron microscopy out of these tiny biopsies we do in the perilesional cortex. Then they get the image to restack. And then you go through the images and you can count the synapses. The images are really black and white. I colored this just for the purpose of showing. But you can see the presynaptic vesicles, you see the postsynaptic density, you see the neuron on the other side. And then you get two people blinded to the treatment allocation and you count the synapses. And you check your inter-rater numbers and all of that. And what we learned is that the two types of stimulation we tested resulted in double the number of synapses at the time we sacrificed the animal. That's about 6 weeks after we turned on stimulation, compared to the sham group, which had half the synapses. So the question here is, okay, there is an effect. Is it neuroprotection or is it neurorehabilitation? Cannot promise. Our suspicion is that it's rehabilitative. And the reason we suspect that is that when we turned on stimulation, the animals were already 2 or 3 weeks out from their stroke. And in a rodent model, the cavity is already made. So it's a mature stroke by the time we begin treatment. We never did it serially, like sack a group of animals every week to see if it's increasing. But our suspicion is that this is synaptogenic, not synaptic sparing. Markers of long-term potentiation and MDA receptors, as well as synaptophysin, that's a protein that is unique to the synaptic vesicle, much more expressed in the therapeutic group than in the sham group. So we took this data, some data that I am omitting here, but I'm happy to send everyone the PDFs of the papers, and had a difficult discussion with the FDA. I know you guys have done this several times. You have a lot of experience. But the discussion here was to do DBS at the time with a device that was not approved, but it was the only group that was willing to partner with us for this. A device that was going to target a therapy that had never been tested with that device or any other deep brain stimulation. And also a target that had never been tested in a US clinical trial. So new device, new indication, new location, difficult discussion. And after several months of going back and forth, we got approval to do 1 patient. The trial was for 12, but the plan was do 1, see how it goes. We'll talk about the second one. After the third one, they told us to finish the study, 12. They were satisfied with the safety. They told us to continue to recruit. So we ended up with a sample of 12 patients who were between 1 year and 3 years out from their stroke. No recurrent strokes. Patients had a single stroke. And they had moderate to severe hemiparesis, no hemorrhagic strokes, no subarachnoidal hemorrhage. All patients had ischemic MCA strokes. And we were talking before, I'm sorry, I don't know your name.
Me?
Yes, James. We were talking with James before about how do you tease apart what is the effect of physical therapy versus stimulation, right, in an open label study. Difficult to do. And we cannot guarantee anything here because it's not randomized controlled, but we try to get a hint. And what we did here, I remember designing this with Dr. Peckham in the room giving me advice. I think Bob was in one of the meetings. John Shea was there. I wanted to do something different. They convinced me that this was the best design. And the suggestion here was to do a lot of rehabilitation and start the study with nothing but rehabilitation. And after 3 months of structured rehab, begin programming, you continue to do rehab, and then you turn on the stimulation. What was the hope here? The hope was to establish a new baseline, meaning rehab these patients to a point that they plateau in their rehabilitation. See what rehab will do for them 2 years later, right? They have not been having physical therapy anymore, right? They're in the community. Then, only then, turn on the stimulation and see if you can push that to a new level. It's not the same, of course, randomizing people to 2 groups, but we were hoping it would give us a hint. And the way that I will show you the clinical data here will be the whole study. I'm going to show you the data combined for the whole study, as well as the data normalized for the day that we turn on stimulation, and then the statistical analysis. You see here that we also stopped stimulation and continued rehab. Why did we do it? We wanted to learn in a phase 1 study, when you can still learn, if there were carryover effects, if any improvement would be associated with loss of its benefits if you withdraw the stimulation, or if what you gain stays with you after you have gained it. We didn't know. I'll pause here for questions. Yes,
Could you repeat questions so we can hear online as well?
I'm sorry?
Could you repeat the question?
Repeat. Oh, there are people online. Well, I'm so sorry. I didn't mean to alienate anyone online. I didn't realize.
So for the participant that you were working with, had they received rehab for the 12 to 36 months or however long it was previous to the study?
No, what happens in the community is that after a stroke and hospital admission, they get discharged, and most commercial payers or Medicare will pay for a few months of rehab, and then they are on their own. So they all had documented completion of rehabilitation, but they were not ongoing rehabilitation for that whole time other than on their own. Before discharging, most therapists will teach the patient what to do at the completion of supervised rehab so they can continue to hopefully improve on their own. But they are not getting supervised rehabilitation by a rehabilitation therapist.
Every patient's stroke is different.
Yes. Dr. Duran is asking, every
Yes.
stroke patient is
It's
different.
different. So how can you make sure that the rehab program they each get is similar in terms of improving their getting a stable baseline for every patient?
So the question is, how do you know that the amount of rehabilitation is similar for every patient? You can't based on stroke size, but you can do it for stroke severity. And what therapists will do is that they will adapt the tasks that are being used for each patient as they progress. So the tasks of rehabilitation are not always the same, even for a single patient. The patient may start with very simple tasks, and as they evolve, the algorithm will make it more complicated as they go. I wouldn't call it a gaming algorithm, but it's not all that different because it's adaptive to skill. But it's not really related to the volume of the stroke. It's related to the skill. Remember I showed you a graph that had ups and downs? So Dr. Plau, Ila, was able to reproduce that in some of our patients with transcranial magnetic stimulation. I gave you some click-clack analogy that you could study the magnitude of the evoked potential in the rodent compared to DBS on versus off. You can do it in people too, just that you're not inserting a microelectrode in the motor cortex, you're using TMS as a tool of indexing the motor evoked potential with EMG. And this is a single patient, it's a single participant. The threshold to stimulation, the threshold to motor evoked potentials, the motor threshold went down when DBS was on, and the magnitude of the MEP went up. And when DBS was sham, the patient's blinded, right? You don't see the same results. So it was a way for us to see if the humans had physiological responses during the acute phases of programming that were somewhat correlated to the ones we had seen in rodents. TMS, very good tool of investigation. Very good tool of investigation. And I promised you the clinical data of the whole timeline. So that's where we start. This is the patient's entry into the study, right? And this is change from entry, right? Most patients were coming into the study with an FMA below 20 or just above 20. And they have not much change during the perioperative phase. And then when rehab alone is happening, they do improve. Actually, they improve 4 points, which is not bad. Some people will say that 4.25 points is the minimum amount you need to improve to say that the improvement is clinically valid. Some people will say 6, some people will say 8, you pick yours. Physical therapy, actually significant improvement here. 4 points, 2 years later, at least 1 year later. And this is the moment here, this line is the moment when we turn on DBS. This here is programming, sometimes it was on, sometimes it was off. And what we found interesting, even in the first subject we noted it, is that the slope of recovery changed. They began to recover faster. and they went to 12 points. This is all comers, people that did well, people that didn't do well. It's the mean of everyone. Yes?
Years or months? Sometimes it's a few years.
Oh, yes, you're right. I beg your pardon. This will be months of stimulation. Each square is a month. But I'm sorry about that. Months again, but now you're normalizing to the day of turning it on. All the physical therapy done before, the 3 months of physical therapy done before, you just ignored. And what was important for us here was a distinction between two subgroups. This group here has 9 people. This group here has 3. The group that did better had a little bit of residual function when they started the study. The group that did poorly, 3 patients only, they were completely hemiplegic. They had nothing left. Maybe this is intuitive to this group here in FES. It was an important lesson for our group. And the important thing about it is that it defines the inclusion criteria for this study that I just began. This is the patient population that we are targeting. This is an exclusion criteria. For us, this was an important lesson. And now the work that was published, right? I'm happy to share with you the paper. This is a published data. Now it's a copy of the paper. And this graph here is color-coded to the time, to the epoch of study. And it's all comers. This one is dividing those that had residual function at the entry from those that were completely paralyzed. So let's take all comers first. Microlesional effect. It's a big thing in DBS. You insert DBS, the tremor improves the next day, right? Just from the mechanical insertion. Doesn't have an effect in stroke. I think it's the first time that I see this. Dominic, you may know more from epilepsy, but it's the first time that I see a DBS therapy without a microlesional effect. Moffat, do you know? Have you seen one before? Yeah, this is the first time for us. Rehabilitation without DBS, it's actually statistically significant, even in a small sample size. You take a group of people that have not had rehabilitation for a few months or a few years. You give them good quality, structured, supervised rehab, they get better. And in orange is the group that had rehabilitation. That's the time when they had rehabilitation combined with DBS, right? And significantly different from the prior. Well, what is the last one here? That's carryover effect. Remember, this box plot is change from the prior phase. So this is change from that, this is change from that, this is change from that. After you turn off stimulation, not that much changes. Whatever they gain, they continue to have for a few months. Do I know 3 years later? I don't. But for a few months, no change. And if you look at the subgroup analysis, separating out those that had a little bit of function at entry, still severely disabled, but a little bit of function, from those that had nothing, the visual intuition here is that everything is kind of flat, except for one box that's really distinguished. Again, for our group, important thing in sub-defining our target population. I'm going to go to mechanism, so I'll stop here. Yes, yes.
Did people report?
The microphone.
Thank you. Did people report any differences, like when they went home and they felt, oh, I could do this and now I lost this function in the carryover, man, I wish I had that back?
No, they did not.
Were there any things they reported that they gained? No.
No, the gains were there. In the carryover effect, we didn't get subjective reporting of major improvements. This improvement, they noted.
They did notice subjective improvements. Were there any specific tests that
in this year, during the treatment phase?
Right.
Oh no, they noted meaningful. I'll show you an example.
Okay.
When you get 15 points of improvement in the Fogel-Meyer, that means you have meaningful quality of life changing benefits to what you can do with the upper extremity. I'll give you an example. and I'll show you Judy, the patient number 1 in the first. Someone who comes in at 17, for example, they have a hand kind of like this, right? Drop wrist, typically drop arm as well. You guys have seen this with the other patients that you treat. You can ask them to make a fist, they will. They cannot open the hand anymore, right? Now it's a fist. So you have to passively open the hand. And if you stick a ball in there, they will hold that ball. If you ask them to put the ball on the table, they can't, right? They go in, they can't lower it, or if they can lower, they use the knees to lower, and then they hit the ball on the table, but they cannot extend. Patients with that amount of improvement can grab a ball, pick the ball, and throw the ball. That's the difference. They can do things like at home. They will tell you that they can now use the good hand to do the more complicated task. For example, turn on the stove while the affected hand is holding the pan. So they learn tricks, right, of what to do with the good hand and what to do with the affected hand. But that other hand was not a supporting hand at first. They can hold the clothes down with the affected hand and use the iron with the good hand. One patient told us that to him, the most important thing is that he could dress himself, zip up, and put the belt on. Because before the improvement, he had to ask a church member on Sunday to go to the bathroom with him. And with the improvements, it's a slow process, but he's able to compose himself alone. And to him, that was the most important thing.
So then going back to the initial question, did he lose that ability after the DBS?
No.
Okay.
There was no decline in function here after the DBS.
Okay.
And it's a short observation, right? Yes, Dominic?
But the level is back to zero.
No. This is change from prior.
Oh.
So every box is change from prior. So this box is the amount of change from this phase. This box is the amount of change from that phase. This box is the amount of change from that phase. Change from prior. Oh, I confused you guys there? I'll say that again. Change from prior. No microlesional effect prior to DBS. Improvement prior to that. Much improvement prior to that. No significant change prior to that. Compared to that. Yes?
Did I understand that there was a difference between patients who had distal function and not distal function?
Yes.
Are these all patients, or are these just the ones that were like the initial responders?
So this is all patients. These are broken down according to whether they have distal function or not. All patients combined, whether they had distal function or not. Here, the translucent orange, the group that had distal function. The opaque orange, the group without preserved distal function. So this is a breakdown of that. Is that more clear?
Yep.
All right. So there are a couple of mechanistic things that we did. I'll start with PET. This is data showing the amount of PET ligand as a subtraction of the epoch during DBS on from the epoch before DBS. So it's a subtraction of DBS on to DBS off. How was this done? Take the patient to rehabilitation, get an IV, start physical therapy, inject a ligand, get the patient to finish physical therapy so that the ligand is going to the brain while they are doing something, right? A task, a rehabilitation task. Run them to the PET scanner to acquire the data while the ligand is still in the brain, right? And we see here a significant gain across pretty much the whole perilesional cortex of glucose metabolism, comparing DBS on to before DBS. And the gain in 3 of these domains was directly associated, directly correlated with the amount of recovery. The greater the change in glucose metabolism, the greater the recovery. And this one, I want to spend a little bit of time with this group because it is the part that I keep nagging Bob to see if I can help, if I can get collaboration from the FES Center, because we need help. Task. This is work done by Raghavan Gopalakrishnan, in which the patient is doing 2 tasks. This one is usually harder. They see this simple pong ball, right? Prep, go, squeeze the dynamometer, hold, and let go. The hard part is the let go. Is opening the hand is the hard part. And what we were trying, what we were trying to do is to see if electrophysiology could guide programming. So I completely glossed over something super important, which is where the majority of the time was spent. Programming. It's a big complicating thing here. This is actual technological development. When we do DBS programming for essential tremor, there are thousands of permutations, right? You do an assessment and you check electrode number 0, 1, 2, 3, amplitude 0, 1, 2, 3, pulse width, whatever, and you see which one causes an acute improvement in tremor. And that acute improvement is what you use as a guide to the chronic stimulation. So if contact 1 at 90 microseconds, 3 milliamperes works well acutely, you're going to assume that it's going to work chronically. And you send the patient home with that, and it does. Now, Dr. Moffitt was present when we did the first 3 sessions of programming, the most boring programming sessions in the history of DBS, where you turn the DBS on and nothing happens other than side effects. The person is perfectly paralyzed 10 minutes after, as he or she was when we began. There is no acute change. How do you pick a setting of stimulation? And thank you very much for coming to those sessions. You helped us a lot. We were hoping that perhaps electroencephalography would. So this is just the 2 examples. Okay? Setting number 1, setting number 2, DBS off, vertical, DBS on, vertical. In setting number 1, I don't even remember what was it. If you look at the power spectra, right? This is seconds. This is the go task. Seconds later, not months, not years, thanks for telling me, seconds. And you see if there is a change in a given frequency domain. And not much there, right? Now in the other setting that we tried, it's just a different polarity. There is a significant change here in the alpha band. We saw this alpha band and beta band changes in some settings. We actually used this as one of the indicators. Side effects were another indicator. We used this as a way to index the expectation of effect, and having an acute effect would indicate long-term effect. What's the difficulty here? This is super time consuming. Okay? If this is going to become a practical therapy one day, not the way to do this. This is dozens of trials, exhausting the patient over multiple weeks. You average them out. Not the way to go. Right? This is not the kind of thing you can give to a nurse for programming later. It is not a viable solution in the long term. We are working to develop a solution, and I bet that someone in this room can help us do that. Complications, right? It's a surgical study. No deaths, no strokes, no hemorrhages when we inserting the lead or later, no infections. Nausea. I think Dr. Moffitt will remember this. Patient number 1, we turn on DBS in one of the electrodes, immediate vomiting. Okay, that's a first. Don't know what it is, we turn it off. Turn it on again, immediate. Go 1 contact behind, turn it on, immediate. Sweetest lady, okay? At one point she tells us, can you stop? Like you have to have learned by now, right? So that was associated with the location of the lead. We had to slightly modify the placement of the lead by a few millimeters to avoid that side effect. And we avoided it. So after the first 3 patients, we learned how to change the implantation and the programming. Surgical pain. the areas behind the head here, occipital, this hurts more than DBS done here because there is muscle. So a few weeks of pain similar to spine surgery, similar to a patient that had a posterior spine surgery. Redness in the chest from prone position. And I will now show you this video a couple of times. This is patient number 1. We're allowed to use her name. This is the first pitch of the game. She was invited to do it. And what changed here for Judy is not so much that she can grab the ball. She could grab a ball before. What was new for her here is that she could open and extend those fingers in a coordinated fashion with the rest of the upper extremity. That was different. I think that I'm ready for my summary. But first, I want to acknowledge a few people in the audience that were pivotal in this study, and I don't know if Dr. Baker is on the screen. So first, Mike Moffitt. He was full-time with Boston Scientific at the time. He came in person for the first programming sessions, red eye, stood there with us for hours until we learned how to interface with the Boston Scientific complicated laptop. And we wouldn't have gotten there without that support. We wouldn't have been able to do it. Ken Baker is the first author of the paper and has been my friend, work spouse, and thought partner for 20 years. 20 years next month. I've been working with Ken. And I hope that everyone in this room has a work colleague as close as I have with Ken. It's really a long-term partnership. And in the room, Dr. Sankari. So Lauren, if you can stand up for a second. This is someone that if you don't know, you should know. She's not going to stand up. Lauren is a Case alumni. You're a Case alumni, right? Yes, Lauren is a Case alumni. JD, who went on to specialize in bioethics. She's a clinical bioethicist. She goes to the bedside in life and death situations to help us figure it out, right? What to do, what's right, what's wrong. She participated and led the consent process for every single one of these patients. Has NIH funding to study that. And you can't understand how important that was for us. I hope you can. Where we had to explain to a group of lay people that had a stroke, totally disabled, depressed, that, yeah, we hope that this works. We have no idea if it will. Explain equipoise. And there is plenty of risk. And make a 27-page informed consent form signed off by the IRB and the FDA comprehensible. One of the things that a form like that does is that it upfront excludes people from a given socioeconomic status because they can't comprehend all that, right? This is not fourth grade reading. And with that, it excludes social minorities, ethnic minorities, racial minorities. It all goes, right? But Lauren was able to help patients that wouldn't been able to participate in this get access to this. And if you look at the sample of this study, if you look at the fine print of this study, and it was actually very well received in the NIH, we were able to recruit the population that is actually affected by stroke. This study had diversity in it. It represents the stroke population the way it should. I want to give Lauren that credit. We wouldn't have done it without you. Summary here, so far, all right? We think that the effects we saw in humans are similar to those that we saw in rodents, that it kind of translates the preclinical to the clinical. We think that the surgery is well tolerated and it's getting better tolerated with our learning curve as we learn how to do it quicker. The shorter duration of the surgeries is helping. The last patient we did last month went home the morning after, totally fine. And I think it's just less time under anesthesia. Patients with just a little bit of distal residual function responded much better. Correlates with cerebral metabolism, much to be learned with electrophysiology to make this a practical technology. And I just want to say thank you to you guys.
So, very nice work. Very
Just a second, Dominic. I think they want to be able to listen to your question in the.
Very nice work. It has some pretty broad implication, I would think. Could you explain some more about where you stimulated, how long you stimulated, why you chose this particular method?
Yeah. Stimulation is going into the output of the dentate nucleus of the cerebellum. Large, very large white fiber tract that goes into multiple nuclei of the thalamus, and from there to a large cortical area. Why did we go after it? Because it is a very large natural pathway that communicates with the perilesional areas, typical perilesional areas, and it's a pathway that is a highly motor pathway. This is a pathway that is the pathway of movement control. Cerebellum, highly involved in learning motor skills, and we thought that it would make sense to augment a pathway associated with motor learning when you are trying to help someone relearn motor function.
Was the stimulation applied at continuously
Yes.
or only intermittently?
No. Stimulation here was continuous. It's not closed loop. Would love to investigate that in the future. You need to come up with a reliable classifier to do that. Again, pitch for the group. Continuous in the humans, continuous stimulation. In the rodents, we're able to do something a little better. The animal facility cycles light at 12-hour cycles. 12 hours on, 12 hours off. The cycle is reversed, right? It is dark during our day, lit during their day, right? During their night. So we clocked the stimulation machines to the light cycle box. So when the lights went off, beginning their nocturnal activity cycle, DBS went on, and when lights turned on and they should go to sleep, DBS was turned off in the animals. In the humans, harder to do, so they were released home with continuous stimulation. They got stimulation whether they were in physical therapy or not. But they were also told to try to use the affected extremity. And the intent there was to see if what we would call ecological use of the affected extremity during the normal day would also have some rehabilitative effect in addition to the moment in which they are getting the formal therapy in front of a physical or occupational therapist. So they got continuous, predominantly 30 hertz stimulation.
Okay, thanks.
Relatively high amplitudes compared to most DBS. Each contact there was turned on to 2 milliamperes. Each electrode, yes.
In your orange box that you showed like halfway through, there's a pretty high variability in the improvement that you saw. Were there any other factors other than residual function that you found had an impact on that?
Thank you. So the answer is no. And I will tell you which ones we looked, but maybe we have other things we should look at. We looked at duration from stroke. Our hypothesis was that people coming in at 1 year after a stroke would recover better than people 3 years after a stroke. Not true. The best responder was actually someone that came in at exactly 3 years. So duration from stroke, not an effect. Volume of stroke, not an effect. Severity of stroke, you cannot tell because everyone was compressed by the inclusion criteria into a small severity group. So you don't know that. You cannot tell from the data set. Yeah, everyone was severe, fundamentally.
Hi, thanks, Andre. I wonder, I may be asking you to speculate a little bit, but with vagal nerve stimulation now approved for kind of a similar clinical application, right? Could you speculate a little bit on how the mechanisms might be similar or different between kind of what you're studying here and what's been shown there?
It will be speculative for sure. Vagal nerve stimulation, and my understanding of it, I never done it, I have only read about it, is a quite indirect polysynaptic mechanism. Here, disynaptic excitatory only mechanism, much closer to the effector. the magnitude of the response we have so far is larger than the magnitude of response previously reported with similar studies in vagal nerve. The invasiveness also significantly greater, more invasive to put a wire in the cerebellum than to go down into the neck.
These are the Fugl-Meyer upper extremity scores. Did you see any difference in the lower extremity scores or function or quality of life?
No, only subjective, and we didn't measure that as carefully. There were very cursory measurements of total Fugl-Meyer in only a couple time points. So the reality is that I don't know. In the next study, maybe we'll catch a little bit more of that.
And have you done any of these studies using the stroke like quality of life index? I can't remember what they are, but there are other things that are
Yes. Yeah.
more behavioral.
Yeah. So I didn't put it here, but Fugl-Meyer is a measure of disability, right? In this one, you have a little bit of hint because that's the AMAT, which is a measure of function. And if you, I'll send you the paper, but we saw improvements in both scales that were kind of hand in hand. They are not so different. He even took his glasses off. Must be a really serious question.
Well, they're not bifocals, Andre, so I can only see here to here with them off. Yeah, a question about programming. Other than the nausea, did you see other side effects? Was there evidence that there's a sweet spot sensitivity similar to what we see in basal ganglia or not? And I guess where I'm going with this is it a bad thing if you kind of stimulate in a broad area? Like we tend to think about DBS as finding a sweet spot.
Yeah. The stimulation was pretty broad because of the amplitude was high. And the practical thing here is that the side effect that limited amplitude most commonly was nausea in those 3 first patients. In the other ones, either we had something pretty mild like a tingle or a vague sensation that they couldn't tell us what it was. One patient had, number 2 patient, had a sensation of tightness with DBS at a higher amplitude. But what limited amplitude sometimes here, actually most commonly, was the charge density. We kept going and we could go to charge density without a side effect.
Thank you.
And of course the agreement, right, the protocol was to stay below it, right?
We have a couple questions from online.
Right.
Ricardo Shu asked, have the participants reported any cognitive changes?
We measure that. So Dr. Darlene Floden is the neuropsychologist in charge of this study for cognitive changes. There were no worsenings that we know. The question is whether there was any improvement, and that we're still evaluating. I don't know yet. And if there are improvements, we would be hard-pressed to know if they are related to the effect of DBS or if they are related to the overall improvement in the person's condition because the person is now rehabilitated more, right, from stroke, is more mobile. So more to come on that.
Okay. And another question, Sinem Balta is, I'm curious if you kept the DBS settings constant throughout the study, was it even possible to keep them constant?
Yes, possible to keep it constant. We had an opportunity to change the setting every month during the programming phase. In the phase 2 study, we cannot. And in some patients we did, especially I think in the beginning of this study, and later we didn't. Right, thank you very much.
Okay, thank you. If you're looking for great